Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
There are a number of exciting advancements happening in cardiology, especially in the areas of diagnosis and imaging, medications, and interventions when it comes to the heart. There are many heart conditions, but what qualifies actually as heart disease? What are the signs and symptoms, and when do you actually go and seek medical attention? During the next hour, we have physicians talking about all the advancements that are happening in cardiology. I'm excited to hear about that. We've been talking quite a bit about it even before the show. That's where I feel like I get all the good stuff. This is underwritten by Hospitals of Providence, and we also want to thank the El Paso County Medical Society for bringing this program to you. I'm Catherine Berg, and this is the El Paso Physician. Thank you for joining us. I'm Catherine Berg, and we are doing a program this evening on advancements in cardiology. And with us this evening, we have a veteran. We have Dr. Shalam Mulukutla, and he is a structural guru, so said by his colleague. But he's an interventional cardiologist, and he does a lot of the structural intervention that's happening with the heart. So we're going to talk about that this evening. And then we also have the newbie, Dr. Clifton Espinoza, and he is a non-invasive cardiologist. So you're the guy that helps diagnose. So when we were talking about the new things in cardiology, a lot of the imaging is relatively new and just a little bit more precise to help people with their diagnosis. So on that note, Dr. Mulukutla, if you can describe what it is that your specialty is about so the audience kind of knows where you're coming from when you answer a lot of these questions.
So my interest is in patients that have, as we talked about, structural heart disease, but what I do basically is I'm an old-fashioned plumber. So basically the idea is we go in there and open up blockages or close them, and then you can add to closing holes or opening holes and trying to patch things up with a little hinge on an extra door or replacing the door altogether.
Okay.
So not that I'm this good at home with handy stuff, but I'm a carpenter or plumber at work.
But it works. It makes sense when everybody is listening to it. And so then as a non-invasive cardiologist, Dr. Espinoza, how would you describe what you do?
So I would describe what I do as more of what people would think of as a traditional cardiologist, where I see patients in clinic. They come in with a variety of symptoms, and I go and evaluate these symptoms and see if they're due to cardiac disease. So mainly clinic-based, we do imaging, echoes, CT scans, things like that to figure out what's going on, EKGs as well. So
okay,
more of the traditional aspect.
Then I'm going to ask you first. The first question goes to you as the traditional cardiologist. So we talk about the heart being a muscle, and I don't think we give it its worth in how much it actually does. So the amount of work that the heart does for the entire body, explain to the audience why it's so important to take care of your heart.
Well, I mean, it's pretty much the essence of your body. It's the pump that basically circulates blood to the rest of the body. Without the heart, your brain doesn't get blood flow, your kidneys don't get blood flow, your lungs don't get blood flow. So I think of it as one of the more important organs, if not the most, after the brain, in terms of function and functionality in essence. So it's the workhorse of your body. Without it, a lot of these things would be very hard to do.
Right.
Kidneys wouldn't function, brain wouldn't function. So I think it's a very, very important organ.
So heart attacks, that's why death happens immediately. Strokes too, even though it's brain, it's also heart associated with that too, because strokes are heart related. And I think people sometimes just think, oh, that's brain related. Dr. Mulukutla, here's the hard one. So we have, and thank you for bringing these, we have structures of hearts on the table. I would love for you to explain, as we're going into everything, what's the best model for you to point at and say, this is what this does, this is what that does. There's blue blood and red blood. Why? There's going up and going back and forth. So I think we just all know it's a pumping machine. But let's describe what parts of the heart does what.
Sure.
Which one? Do you want me to bring this to you?
Sure, yeah.
Okay, let me bring that to you.
The simplest way to think about it is if you take your fist, your heart's usually the size of your fist. So babies are smaller, obviously, and then as they grow, the heart is the engine that works. I like to describe it as twins. So everyone, well, I'm getting older, but Danny DeVito and Arnold Schwarzenegger were part of the movies. So the way I think about it is the blue blood, as you described, will come to the right side of the heart. And the right side of the heart's kind of Danny DeVito or a Vespa. It's going to pump it to the lung arteries, which is going to go get oxygen, and then it's going to come back through the pulmonary veins to the left side of the heart and go down to Arnold Schwarzenegger or your Harley and get pumped out to your body. And that's what Dr. Espinoza was saying is the importance of the heart, because it's now bringing the oxygenated blood to the entire body. And it's sort of like a washing machine. It's rinse and repeat, because this is doing it thousands and thousands of times during the day and millions of times over your lifetime. And this is where the right side of the heart gets the blood and then pumps it to the lungs. And then the left side of the heart then pumps it to the body. And there's 4 chambers and 4 doors.
So say that again. One side pumps to the lungs, the other side pumps to the entire body. I've never heard it explained that way before, but that's really nice to picture it that way.
It's sort of like if you really wanted to go back to your engineering days or where they made it like in series and in parallel. And so one side, it's like your kids, I got 2 of them. If they're locked in their room, they're not going to talk to each other. And so one side is going to be doing its job, and then the other side does its job.
Right.
And then you sort of pump through these rooms and these doors, and at the end of the day, and the body gets what it needs, which is the oxygenated.
I love the way you explain these things. Okay, nicely said. I know I interrupted you. Okay, keep going. So valves, when I say that too, you're looking at these, we're going to talk about valves tonight. And we also have some footage that's going to be interesting to see. Yes.
So the other thing I was going to tell you is actually what we sometimes talk about is your blood pressure, right? So your blood pressure is real important to your heart. And what I was going to say is the blood that's pumped out to the body, the heart actually then, the blood comes backwards to the heart, and then it goes into the coronary arteries, which is the arteries are kind of like the gas that feeds the engine.
Right.
And when you have a blockage in those pipes, then you get the heart attack or the problems that you were describing.
So on that note, and I have it further down on my notes, but let's talk about, we all know blood pressure readings, and there's the top number and the bottom number. So the top number is systolic, and then the bottom number is dystolic, right? So diastolic. When people are getting their blood pressure, describe what the top number is and what the bottom number is, and physiologically what's being measured in the heart. Dr. Espinoza, that's thrown your way.
So when I explain this to my patients, I usually tell them, yes, there's 2 numbers, because I usually refer to it as the top and the bottom.
Exactly.
So the systolic blood pressure is a consequence of the pumping force of that left ventricle. So it's that immediate pressure generated by that chamber and, the blood leaving the heart and going to the aorta and the subsequent arteries of the rest of the body. So that's your systolic blood pressure. Your diastolic blood pressure is the relaxation phase of the heart. So the blood is that pressure after the heart started relaxing and that aortic valve is closed. And believe it or not, the blood that goes to the heart through the coronary arteries is dependent on your diastolic blood pressure.
And that's
why that one's important. Because if you have low diastolic blood pressure, then that means those coronary arteries aren't getting very good blood flow. So that's the difference between your systolic and diastolic. It really depends on the cardiac cycle. So most times patients are worried about the top number.
right.
Where, my top number is very high, but diastolic blood pressure, with it being high, it can also cause problems as well. So they're both equally important, but that's the main difference between the two.
So if you had like the perfect specimen, not Arnold and not Danny, but the guy in between, what is the perfect blood pressure reading?
So classically, they would say 120/80 is your perfect blood pressure. But, over the years, there's been a lot of controversy as to what's normal or considered the good blood pressure. At one point, we were allowing blood pressures to go as high as 140/90, about 5 to 10 years ago. But then eventually we noticed that, hey, maybe this isn't the approach we want to take, because we were noticing some detrimental effects of allowing the blood pressure to go that high. So then we lowered down to 130/90 is more where we try to keep patients. Ideally, the lower you have it, the better you'll do overall.
Right.
But generally,
unless it's too low. And I feel like we never talk about those people who, like, I'm that person. I have historically very low blood pressure, not in a good way. People say, oh, that's nice. But they were worried when I was pregnant, having a baby. It's like, oh my God. I'm like, I promise you, this is usually how I am. But I'd like to incorporate that somewhere in the program, because I'm not the only one. There are people that just have, they feel faint a little bit more often. They do gardening and stand up and they need to grab onto a tree, and I'd like to know why. And we can talk about that in a bit. But you had something else you were going to add.
Yeah, so blood pressure is really important. And the part that we were going to talk about, I guess, is, from the risk factors for the heart that I tell patients from this is that I call them the FAV5. I call them hypertension, cholesterol, diabetes, family history, and smoking. Those are my 5 for the heart that I'm always worried about. And blood pressure is a very important one. Controlling your blood pressure is imperative, because that, if we did that, would reduce a lot of heart attacks. The other thing that's really interesting that we don't do a lot of, but has been studied, is checking your blood pressure once in your lifetime in your right arm and your left arm. And the reason they found that is there's these 3 vessels that go, and they go to your arm, and they go to your arm on both sides. If there's a difference in blood pressure of 10 to 20 millimeters of mercury difference, meaning this side's 140 and this side's 120, that's a simple screening test to tell you that you may have blockages. Because if you're developing blockages in your arteries that are up here, most likely you may have blockages in your arteries of the heart. So it's a simple way to do it, and they found that this was very effective. So we don't typically do it. We just, when you go somewhere, they check your blood pressure on the right or left arm.
Right.
But at some point, you should do it. You should do it in the same setting and check both to see that they're the same.
Well, now I'm going to do that next time I go in.
Yeah, they may get mad at me, but
Totally going to blame it on you. But it makes perfect sense. I mean, just explaining it that way, because you've got different pressures on different sides of the bodies for blockages. So again, physiologically, it makes absolute sense when it comes to that. When you say controlling your blood pressure, let's talk a little bit about medications, because I know that, there's a little bit of controversy on that back and forth, but in general, hypertension, how is that medicated? And whoever wants to take that.
Well, it really depends on where exactly you are in the spectrum of hypertension, right? Because if you have a patient that comes in, relatively young, blood pressures in the 130s systolic, upper 80s, diastolic, you wouldn't necessarily rush immediately to put them on medication.
Right.
You would advise them to institute lifestyle modifications, reduce salt intake, increase your exercise. You give them a few months and see if the blood pressure normalizes with that. If for whatever reason they're doing everything right, the blood pressure still remains high, then you may consider putting them on medications. Now, on the other end of the spectrum are those patients that, come in with blood pressures above 140, 150. Generally, lifestyle modifications won't be enough to bring them back to where they need to be. So those are the patients that you still are going to recommend that they diet and exercise, but you may consider certain medications. Now, the circumstances also depends, because it's patient to patient. Some patients might have issues with their kidneys where you may not want to use certain medications, where otherwise their kidneys might be impacted. Or they might come in with, let's say, low heart rates. So beta blockers may not be a good option there. So there's, different classes of medications that can be used. There's the ACE inhibitors that work in the kidneys. Angiotensin receptor blockers are kind of cousins to the ACE inhibitors, and those work very well in controlling the blood pressure. But again, you also have that impact to the kidney, where you have a patient that already has chronic kidney disease. You may be limited in their use. Same thing with the diuretics. Diuretics like the thiazide diuretics are considered, first-line medications for controlling blood pressure. But again, certain patients may not be able to tolerate those medications, like patients that have gout, patients that have kidney dysfunction, electrolyte dysfunctions. So you would consider things like beta blockers or calcium channel blockers. So it really depends on the circumstances. Not everyone's going to have necessarily the same medications right off the bat.
So here's a question. You used the word cousins a moment ago. So when I think of hypertension, I think also of cholesterol, right? Like, do they go hand in hand? Are they siblings? Are they cousins? Does it always mean that if you have hypertension, that your cholesterol is something you have to look at? Explain how that goes, because I feel like they go hand in hand, but maybe that's not always the case.
They can.
Okay.
A lot of times, these guys tend to be together, but they can be separate. If you have a family history of high cholesterol, you may be somebody who is prone to that. And similarly, if you have a family history of blood pressure, you may be prone to that. In patients that have diabetes, we are now very aggressive with treating them with cholesterol medicines because we know that diabetics, we explain it as if they're a higher risk for heart disease, but in reality, sometimes we even say a diabetic may be the equivalent to someone who's had a heart attack because their risk is so high. As a result of that, if you are a diabetic at a young age, you would be put on cholesterol medicine because of the risk over your lifetime. So the reality is a couple-fold. The other thing I'd also say is blood pressure is related to a lot of lifestyle changes or lifestyle issues. People who have obstructive sleep apnea and tend to snore at night and may have the need for breathing machines like a CPAP machine that we talk about. Even simple modifications where we treat that can lower their blood pressure. And people who are out of shape and may be obese may, as a result, have a higher propensity for blood pressure, cholesterol, or diabetes. And so as a result of that, as you described, those things may run hand in hand. But treating sleep apnea could also be a reason, in addition to medications, that might help hypertension. So it's sort of like a holistic approach, but there's a lot of things that sort of run together with it.
Mm-hmm. I am going to switch gears a little bit and talk a little bit about electricity in the heart, because I feel like there's so much involved there. So this is like the structural stuff. And now you were joking about, not joking, we were talking about AFib prior to the show. There's arrhythmias, there's palpitations, there's AFib, which I guess is arrhythmia. Palpitations, basically you just feel your heart going. In general, and I'm going to take it to you for now, to the general, or what did you say, the classic cardiologist. When we all have palpitations, we think sometimes we shouldn't feel our heart, but when we do, we get a little worried, like, wow, my heart's beating really fast, but I'm not running, I'm not doing anything. Describe what that is and why people get concerned, and then take it into arrhythmia, AFib, et cetera, because I feel like that's something that you hear about all day, every day right now. You're on TV, on podcasts, on everything.
So you go to any cardiologist's office, you're going to have a patient that's going to come in complaining of palpitations at least one, if not multiple times, during that clinic day. So generally, you ask them, well, what do you mean by palpitations? So they'll tell you, oh, I feel like my heart races, or I feel like my heart is fluttering, or I just feel my heart just going at it. So there are some arrhythmias that we consider benign. There are some arrhythmias that we consider dangerous. So some of the benign arrhythmias would be, like your premature atrial contractions, to a certain degree, premature ventricular contractions. So these are contractions that are occurring when they shouldn't be, from the top chambers or the bottom chambers. So your natural pacemaker in the heart dictates your heart rate and how, that electrical system is working. But all along that electrical system, there can be little spots that can fire prematurely. And sometimes those can, give you that sensation of a skipped beat. And sometimes patients will feel that. Generally, those are benign, as long as they're not occurring at a very high burden, as we call them. Now, your malignant arrhythmias are those that are your ventricular tachycardias, meaning there is a focus in the bottom chamber that's just causing the heart to go really, really fast. And the faster that heart goes, the less time that chamber has to fill with blood. So then your blood pressure drops and patients can pass out. And if that continues, the heart muscle will start suffering from inappropriate blood flow and oxygen. And then they can, have a cardiac arrest.
And are there any causes for that? Is that just something that you have inside of your body when you're born, eventually it will show up, not show up? Or is that, I guess my question is, can you prevent that from happening? I know we were talking about lifestyle, obesity, diabetes, et cetera, but in general, is that an inherited type of a condition?
Well, there can be inherited syndromes where you are prone to developing these malignant arrhythmias. One of them can be something called long QT syndrome, where there's a certain segment in the electrocardiogram that is prolonged and it's congenital, and that can increase your risk of having these bad arrhythmias. But when you see a patient that comes in with ventricular tachycardia, one of the first things you want to think of is there a blocked coronary artery? And that's one of the first things you want to evaluate. Is this person having a heart attack? Is there ischemia going on? So right off the bat, any cardiologist tell you, okay, there's VTAC or there's a ventricular arrhythmia. Maybe I should start looking for, some sort of ischemic event in that muscle.
Okay.
The what I usually like to tell patients is, I sort of use the same analogy, but I say the top part of the heart tells the bottom part what to do. So I call the top part like the woman, and the bottom part the man, and so it goes boom, 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 and that's what happens in my house. But in any case,
and we have one other woman. She's sitting on the couch over here. Immediately, she looked up like, "What? No." But this is a great description. Exactly.
And so what Dr. Espinoza is describing is a lot of different types of rhythms, but the basic idea is if you have abnormalities in the top part of the heart, generally those rhythms we call supraventricular, above the heart, above the ventricle, those are not necessarily going to be life-threatening, generally speaking. And the ones that are in the bottom part, the ventricular arrhythmias, can be life-threatening. And the other part to it is you sort of evaluate this. Sometimes people have their heart beating fast or not. So then the other part is this normal fast or normal slow? Or abnormal fast or abnormal slow? Right. And really the way we do this is we do different tests. We may do a heart monitor, do an EKG. There's a lot of different ways we can evaluate it, but we also want to make sure if it's something serious that there's not structural problems with the arteries. So then you might do stress tests and different other things. There's a lot of ways we can evaluate the heart without going inside of it. And so that's what we would do. The majority of patients coming in, they probably don't have those significant issues, but there are a percentage of patients, because when you're getting sent to the heart doctor, you've probably been seen by your general doctor,
exactly,
other people. So there's a level of suspicion. So there's a combination of things. And I'm wearing one of these Apple Watches are great. I always joke they're good for business because they say all kinds of stuff. And people come in saying, I've been monitoring my heart rate, but I never used to do all those things before 10 years ago. Now we know every single thing that we're doing. I slept 6 hours and it's my average heart rate. So that's a lot of this stuff has created some angst, but it's also good because technology is getting better and better. And so it's helpful, but there's a lot of things in there that you have to parse out to figure out if it's real or not.
Exactly. And I always think when I have that opportunity in any program, Dr. Google can be a dangerous man, right? So, yeah, he can be. So on that note, how many patients come to you and say, hey, I looked this up, my watch, Dr. Google says this and that and the other. How do you usually address just generically those questions and those comments when they come to you?
Well, you got to see the big picture, right? You always have to see where the patient's getting their information or the source. Is it a credible source? Okay, fine. Credible source. Now you have to see, are your symptoms really that consistent with what you looked up? You always have to have a certain degree of suspicion, like Dr. Mulukutla said. You can't just, nod off and disregard the patient. You always have to kind of take everything into account, and then you explain to them, okay, this is what you have, this is what I'm seeing, this is what Google is saying, but this is what is correlating with it, and this is the reasons why it's not correlating with it.
Right.
So you always have to kind of sit the patient down and explain to them, okay, I understand your concerns, but based on the testing that I've done and what I'm seeing, this is what I really think is happening.
Right.
And then I'll point you in the right direction where you can get more information about that. But yes, Dr. Google can be very dangerous.
Yes, he can.
I've had so many patients come in already diagnosed themselves with certain syndromes that, you'll be lucky to see one in your lifetime.
And I do a lot of research on WebMD. And honestly, that too can be confusing because, number one, you have 20 million ads in there, right? So the nice thing is to go to your clinics and find out from you all which web-based Q&A you should go to. You said something earlier about how to evaluate different issues with the heart. And I know that there are some just new imaging. We were talking about that at the beginning of the show. What type of imaging are we using now today compared to 5 or even 10 years ago that's helping you, the man that diagnoses stuff, that's helping you find out what's going on with the heart?
So basically any type of imaging modality that exists out there can be used for the heart. So the premise, the most basic, tool that we use is an electrocardiogram. And that's or is better known as an EKG. And it's just mapping out the electrical activity of the heart right then and there. And it can give you information in terms of arrhythmias. Has this patient had a prior heart attack? Are they having a heart attack?
Right.
Things like that. Then, you move to your more complex imaging modalities. So next up is your echocardiogram, which is essentially an ultrasound. The way I explain it to patients is the same machine that's used to look at a baby when they're in the mother's womb. You're doing the exact same thing. It's painless. They put a little gel in your chest, take pictures of your heart, and it gives us structural information. How well the ventricles are squeezing, how well the heart's relaxing, how do the valves look, is there a tight valve, is there a leaky valve, things like that. Then you move to even more complex modalities. Now you have your CT imaging, MRI imaging of the heart, and each one looks at a different aspect of the heart. So cardiac CT can look for certain structural abnormalities. We use coronary CTAs to see the anatomy of the coronary arteries, is there plaque within the coronary arteries. The other thing that we use is stress testing. So we use a nuclear camera to determine what the blood flow to the heart tissue is looking like. Based on that image, you can infer, okay, this person has a significant blockage in this artery of the heart. If you want to take it a step further, there's something called cardiac PET CT. That's a different stress testing modality. Uses a little bit different medicines to stress the heart and image the heart, but it does give very good image quality. So all those modalities are available.
So there's not really any guesswork in it anymore like there was in the past. You pretty much can, for the most part, diagnose things. Or he says that the little bouncing...
There's still an art to it.
There is.
You need to know, based on your symptoms and what you're looking for, that will tell you what modality you use. And even then, you might not get the results that you expected.
So and I love the word symptoms, because I feel that with cardiology, sometimes there are no symptoms until there's an event. And I would love and I remember us talking about this a couple of years ago. You so beautifully explained that, boom, there's a heart attack. And people say, was it a big heart attack? Was it a small heart attack? Is that even a thing? A heart attack's a heart attack. And the person who eats well, exercises, is in good shape, all of a sudden they have a heart attack. And so nobody knew that there was a problem, because the assumption was, well, I'm doing everything right, I look right, I feel right. But there could be, like you said, a blockage somewhere and nobody knows. So talk about those types of cases.
Sure. So when we're talking about patients and evaluating it, the important symptoms that we talk about are our shortness of breath, some fatigue potentially. We talk about chest pain or angina, which is, to different people, different things.
Right, that's true.
And so chest pain can be very challenging at times, but when you have pain in your chest, it could be concerning because you really don't know. And what I tell patients is, between the skin and the heart, there's a lot of structures. There's the muscles, there's the rib cage, there's the lungs. So you could have muscular pain that might be this. And so you try to figure out, is it with movement? Is it not? It should not be reproducible. It should be pain that is there, that cannot be changed, and it lasts for 5-10 minutes, and it may feel like an elephant sitting on your chest. There's all these terminologies, but the reality is some people have symptoms that are completely different, and they could be having a heart attack. And then there's also people that pass out and they don't wake up, and that also is called syncope, and that is...
You mean they pass out and don't wake up for... how long?
Depends.
Okay.
And these are all the major symptoms that we look at.
Okay.
But the most common symptom is really just fatigue or shortness of breath.
Okay.
The problem with the symptom is that it's very common with everything that we do, right? And the other part to it is, the importance is, when you have these symptoms and you have something like this happen, then you want to be evaluated. When you have a heart attack, there's two major arteries there's three major arteries, but there's a left and a right artery. It's right. Simple. And the left artery is like if you're going up to Cruces and I-10 and I-25 split. And then the right artery generally goes to the back part. So if there's a heart attack, the first thing that someone does when they come to the emergency room is they get an EKG. And the EKG is beautiful because it can tell us if there's an acute heart attack happening right then and there that we need to do something about. You can have a silent heart attack, which means that maybe there's blockages, but it's not something the EKG is picking up. And so over time, if we get blood tests to look at your heart enzymes or damage to your heart muscle.
Oh, I remember that. Yeah.
And then you can see over 24 hours if there is. So we have two terminologies. Heart attack, which is STEMI. We use that, which unfortunately I'm on call for tonight. And then non-ST elevation MI, which means that there isn't an acute, but it is still a heart attack that's occurred because of the damage that we can see with these enzymes or these lab tests. Which,
even though the person may not have...
And they may present the same way.
Okay.
They can present potentially the same way.
Okay.
But it's amazing to me that if someone has an acute STEMI, you can go in there and we'll have all these fancy tools that we talk about and go into the artery from our arm or from the leg and then go in with a little wire and a balloon and you just open up this vessel that's 2.5 or 3 millimeters. And then all of a sudden their symptoms can go away.
That's amazing.
Because the heart muscle is much like a plant. If you don't water a plant, then it's going to die. That's why there's no plants in El Paso. There's no waters. But the point is, it's the same idea as if you don't get blood to that muscle, and as you get that blood to the muscle, then it goes away.
So you hit on something beautiful that I have here too about the heart blockage treatment. So one of the new treatments you were talking about is a balloon, but there's a drug-coated balloon. So we talked about this a little bit last time, and the way that you described what the medication on the balloon is doing, this is like, I don't know if this is instead of stents, or is this an additional treatment with stents? I'm assuming it's instead of stents. If you can explain, as the guy that does the procedures, what's going on with the drug-coated balloons is how I have it written down here.
Yeah, so these are new technologies, to be clear, that have come out in the last year that are still in the process of being used currently. The FDA has recently approved some, and I think in Europe they're using it more commonly for other things. But the short of it is, when there's a blockage, we take a wire that's 14 thousandths of an inch, tiny, tiny thing that goes past this blockage. And then we usually balloon it with stiff balloons and soft balloons. We open it up and then we put essentially a metal stent. It's basically, if you take your hand, it's a cage with metal scaffolds around it.
Okay.
On the metal scaffolds, we determined over years that if you had a drug on it, it helped the healing process so the body would accept it and wouldn't close the artery.
Oh, I see.
Because in the past, they would use balloons and they would close.
Gotcha.
And they used stents, we called them bare metal, which is a funny word, but basically meant they didn't have drug.
Right.
And then they closed. Then they used drug. So that's been what we've been doing for many years now.
Okay.
Recently, they found that you could use maybe a drug-coated balloon without a stent, and you may be able to have results within arteries that had blockages within the stents, like let's say your stent blocks up.
Okay.
Or now people are using it in areas where you wouldn't want to put a stent. Maybe there's two that are coming across, like I talked about bifurcation.
Right.
Maybe you could balloon this area, leave the stent. Or maybe the vessel's too small for a stent. You could balloon it. So there's a lot of applications that are exciting from that standpoint. And it's a new technology that I think has a lot of promise, because you may be able to leave no stent behind in certain situations, because we know over time having less is more.
Right.
Or at least that's what they say.
And I'm listening to you with stents, and I'm thinking to myself, scar tissue. Is that something that, and now I'm thinking stents are old-fashioned, and a long time ago when we did stents. But is scar tissue ever an issue with stents? Is that one of the reasons this is?
Correct.
Okay.
So the short answer is stents are a workhorse if we got to do something, because that helps keep the vessel open and from it collapsing. So this is something in the future may change. But the stents sometimes can also have buildup of schmutz or junk inside of it. And that's the scar tissue you're talking about. And there's different reasons for it. But the drug-coated balloons have been shown now, and that's what they're FDA approved for in the U.S., that you can put it and balloon those areas, and then you might no longer have that gunk built up again. That's what we're talking about currently. But the application in the future may be in other spaces.
Okay.
And that's what I'd say in the next 3 to 5 years, you might see more of this kind of stuff.
That's why I love doing these shows. Like, February is always that month, like
What did we not talk about last year? What's new this year? I'd like to transition a little bit on medications and what we're hearing a lot about these days. So we are looking at diabetes. Let's talk about that first. So addressing diabetes medications, and we talked a smidge about this before the show started. So SGLT2 inhibitors, which is, again, that's the Farxiga type of medication. And then there's the Ozempic type of medication, which we're hearing a lot about too, and that's the GLP-1. I would like to kind of clear myths. I'd like to maybe set the record straight. Why is there such an influx of people running to get these medications that don't necessarily need them? Some think, well, I just want to lose my extra 10 pounds. I think medically, it's really nice to talk about that this evening, because I feel like every morning show, medical show, news show, it's being bombarded everywhere. We're running out of this drug. We have too much. We have too little. Dr. Espinoza, I'd like for you just to start on it. If you want to hop in here and there, that would be great.
So the craze for these medications is particularly for that, the weight loss, right?
Yeah.
So originally, these medications came to the market for managing diabetes. But one of the side effects that became desirable of these medications is that patients were losing a substantial amount of weight, mainly because these medications tend to curb your appetite. And there are some other metabolic effects that helps patients, lose weight. So that's why the craze for these medications is ongoing right now. Now, it's not to say that these medications are bad. No, they do have, certain properties that make them desirable in certain cardiovascular patients. Some of the GLP-1 agonists have been shown to reduce mortality in patients that have both diabetes and coronary artery disease.
Okay.
So they're helpful in that sense. We have an obesity epidemic. So these medications are helping to control that in a sense. I've had certain patients that have gotten on the medications for managing the diabetes. They've lost 30 plus pounds. And I've actually had to cut back on some of their antihypertensive or blood pressure medications because now their blood pressure is too low. So they're very good medications. Now, they do come with side effects. Some patients can have nausea, vomiting, stomach upset on injection days. There's always a possibility of developing, gastroparesis as well with these medications, which is paralysis of the stomach. But that's a very rare, occurrence. But that's really why these patients are looking for those medications, because they don't have to spend the 80 hours in the gym, in order to lose weight. They basically inject themselves every week and they'll lose weight. So they're kind of, in a sense, taking a shortcut. But that's not what these medications were meant for. They were meant to help these patients with diabetes to better control their symptoms. And we quickly learned that, as a side effect, patients will lose a substantial amount of weight. Now, on the other side are the SGLT2 inhibitors. Now, those also came to the market for managing diabetes.
Okay.
They work a little bit different. They help eliminate excess glucose in the urine. But the utility for them is actually in heart failure in those patients that have a weak pump.
Okay.
So the SGLT2 inhibitors are one of the 4 pillars that we consider that is the mainstay of treatment for patients that have pump failure. So they help some of the negative remodeling that occurs in these heart failure patients, and it helps their heart function better. And then at the same time, it helps them eliminate excess fluid. So you're able to cut back on their water pills. In some patients, it may help them lose a small amount of weight, but nothing compared to the GLP-1 agonist.
Okay.
So, that's where we use these medications. It's not to say that we don't, but predominantly those are kind of the realms where I used these medications for.
Okay. Well, I appreciate you kind of explaining the difference between the two. And do you feel that people are just using these for weight loss, or these people, for example, when they come to you all, but when they get their prescriptions, Are they doing it partially diabetes? Are some coming just for weight loss? And is that something we see happening going forward in the future, or development of these type of medications? Because you said earlier too, year 5, you said hypertension, cholesterol, I can't read my writing here, family.
There's your way to being a doctor.
There's family history, and diabetes, sorry, and obesity. Yeah. So you were talking about the obesity. That's one of the biggest ones. So if you're looking at eliminating the obesity, just in general, that helps with everything else. To your point, it's running and the gym, and there are people who just have a much harder time losing weight than others do. And I don't want to dismiss that in any way, shape, or form, because people with all their might gave it the college try, and I've eaten right and I've exercised and I just can't lose the weight. Do you see these drugs being used in those cases, even if they do not have diabetes?
Yes.
Okay.
So the problem is that, yes, these medications, you'll get a prescription from your primary care. Let's say you tell them, hey, I've tried everything I can. I'm still overweight. I'm pre-diabetic. Can I get a prescription, or do you think this would be a helpful medication? And most times the PCP will say, yes, absolutely, it will help you lose weight. Here's the problem with those medications when they are prescribed in non-diabetics. The insurances will not cover the cost of these medications. They can be very expensive. The other problem that is occurring, and we see it in El Paso quite frequently, is that now you have all these patients that are trying to use these medications for weight loss purposes. And it's making it difficult for the patients that have diabetes that need these medications to be able to find them. I've had patients that have waited up to 3 months before they were able to receive their usual dosage for some of these.
And these are diabetic patients that really need it because they're being taken elsewhere. Okay. Yes, Dr. Mulukutla?
The obesity epidemic drives blood pressure, cholesterol, and diabetes, and we call it metabolic syndrome, which are various ways to describe this. As Dr. Espinoza was saying, as you lose weight, you tend to lose some of these problems, so we've had to cut back on different medications for these patients. The benefits of these medicines initially, and when we talked about diabetes, there are other diabetic medicines that have come out, and as a result of that, with diabetes, we now have all diabetic medications have now been asked to do cardiovascular assessments, because we are now finding that there's so many benefits that we didn't realize. The SGLT2s are beneficial in heart failure. GLP-1s work on the hypothalamus. That's why it decreases satiety. So you get early satiety where you're not hungry. The other things that we would like to say with these medicines is they are relatively new. We're learning a lot. Patients have to be very careful how they take them. When you have the medicines, you may be titrated up to a certain level to maintain weight or lose weight, or to improve your hemoglobin A1C, which is the glycosylated hemoglobin that we check to see your diabetes is well controlled or not every 3 months. The other thing we're finding is, yes, you may want to use this and it has the benefit of weight loss, but if you come off of these medicines, you may also gain the weight. So it is not that you can just take these medicines and come off. It may be also a sustenance or a maintenance that you have to be on with these particular medications. And we're still, each person's different. Is it okay to use it in this and in that? Those are all things that are open questions.
Right.
I think they have a great benefit, but there's a simple study that was done in Britain which showed that even if you didn't lose weight and you did 15, 20 minutes of exercise, those people's cardiovascular benefit and mortality was less than those that didn't. But the point is, just being active is also beneficial. So we want people to be up and moving regardless of their age group, because walking and being active and exercising has benefits.
And as we discussed in the very beginning of the program, the heart is a muscle, and you have to exercise the heart, but not work it too hard.
That's right.
Not working it too hard. I'd like to go back and talk a little bit more about valves. We have TAVAR, subtrans aortic valve replacement. I know that in general, there are like mitral valve, I have a mitral valve issue. I do have regurgitation. For the most part, it's chronic, but relatively benign, but it's something that I know I have, and I'm always curious when these issues come up. And then there's also other valves that are frankly more important. So in my opinion, I feel like if I'm going to have a valve issue, mitral valve's okay. But in general, actually, you know what? I'm going to stop for a second. I'm going to go to this because we talked about the joke of this earlier. Hold off on the valves for a second. We got a whopping 13 minutes. So let's talk about severe aortic stenosis. And you said, okay, go ahead. Should I do the...
Yeah, because the crew really wanted us to do this.
Yes, okay.
They wanted you to put your finger in the bottom one.
See, it just sounds like a bad joke. That's why I was like...
This is not a Bart Simpson joke.
All right. It's not going to electrocute me or anything, right? Okay.
Bottom one.
Bottom one.
The bottom one is the one that's normal.
Okay.
And then you can take your finger back.
All right. Doesn't feel too bad.
And then the top one.
Oh, wow.
So what I find interesting is I can talk about all the stuff about your valve all day long.
So this is the normal one.
But patients really understand this more than anything else. Because the bottom one is opening normally. And they say, well, that's what's happening to my valve. That's how it's not opening. And so I say, it's like a pinhole. Whereas the other one is your normal valve when you were born or as you grew up as a teenager.
And flow in and out very easily, I can see.
Correct.
Okay.
So the reality is when you build up blockage or calcium, you can do it everywhere. In fact, they know by the age of 13, you're already building up certain blockages in your aorta and plaque. And so this plaque and buildup is happening in the aortic valve or the mitral, wherever it might be. And then this is a good example of where patients who are pumping through that pinhole, now we understand why there's a high mortality in 2 or 3 years where 50% of the patients will die if we do nothing.
Right.
Sort of walking towards a cliff, and if we didn't take care of you, you might fall off, even though you might feel okay, or you're having some mild shortness of breath. And what happens with patients is very common. You can't do something, so you sort of ratchet it down. And you, instead of going V6, you're V4 or V2, and before you know it, you're not doing a whole lot. So I always teach our residents that rotate with us, and they come in, or the fellows, and they say, oh, they're not having any symptoms. So the question really is, what are they doing?
Right.
Because if they're not doing a whole hell of a lot, then you're not taking the car out for a spin. You're just basically jogging around and not doing much. You might not be able to tell. So that's why we talk about heart attacks and heart diseases being a silent killer with high blood pressure and all these different risk factors. Because if you don't mend it for a while or take care of it, at some point, you got to pay the piper. And these are the things that are important for us.
Right. Nicely said. I'm glad that we talked about that. And two, when you think of calcification, you were talking about blockages and calcification and just building this up. When you think, and just for the audience, it just feels like very, I don't know how to describe this, as very soft rubber. We can go through it, and this just feels like hard nodule rubber. You can't really get in there, nor can you pull your finger in or out nicely or easily.
And the way I describe it is like a door in winter that's getting stuck.
Yeah.
And then as it gets more stuck, it's harder to open. And eventually, for many years now, almost 50 years or longer, what we had the surgeon take the door out and replace it. They would put you on the heart-lung machine, drain the blood out of the heart so they could work in a bloodless field.
Wow.
Then they would basically remove the door and put a new door in. And so what's changed today is almost 65-70% of all aortic valve replacements, which is the last stop on the train station before the blood gets out of the heart, is now replaced without doing open heart surgery, but you can replace it by doing this TAVR, TAVR procedure, where you go through the groin and you can replace the heart valve, and I'll show you here so you can see it. But basically, you put one of these things, and this might be harder than what I can do even during the surgery, but it's going to go in right there.
I don't know.
Maybe this one doesn't fit correctly.
Yeah. Okay.
But basically, this valve is going to go in there, and it's going to fit right where your old one was. And for technical difficulties, we're not able to put it in. But the short answer is you don't have to cut out the valve. What this does is it pushes out the old valve, and what you see is inside of it now, the new valve. And this is made from the heart sac of a cow.
Okay.
And it takes, I think, when I went and visited this lab in California, it was old seamstresses who'd done this for a long time. It takes about 12 hours to create this thing, each one working for an hour or two on their part. And this is the thing that we have that we can blow up with a balloon now, much like we do with the coronary arteries, and do a life-saving procedure. And we can do it with the patient, come in today and go home tomorrow.
That's amazing to me. that that's even an option now. And so, yeah, Diego was just looking at this other one over here. Let's see if we can pass this other, the one in the corner here.
Oh, this is
Yeah, is that the same?
This is different.
Okay.
This is related to AFib. I
Okay.
don't know if we would like to talk about it, but I did.
Well, let's do, since we kind of have the same
What is
process.
Dr. Espinoza can tell us about, things that how he treats AFib, because this is one modality.
Okay.
We did several of these today, but this is an option for patients to get off of blood thinners to prevent one of the concerns, which is stroke.
Right.
But there's a lot of things with atrial fibrillation that are important, and it goes back to our palpitations discussion.
Okay.
Right. So
I'm an AFib girl. So again, I'm very curious about this, and stroke is something I worry about.
yeah. So Dr. Mulukutla says, the top chamber basically tells the bottom chamber how to do. So the top chambers usually pump in synchrony, and then the bottom chambers pump. With AFib, they're basically quivering. They're not pumping rhythmically. They're just quivering. So what happens is that those electrical impulses is very disorganized.
Mm-hmm.
So all those electrical impulses are bombarding the bottom chambers. So it causes the bottom chambers to beat irregularly and fast. And that can cause symptoms. The patient can feel palpitations, it might feel lightheaded, things like that. Over time, if the heart is in that constant tachycardia and irregular rhythm, the heart can weaken. So they can sometimes develop a type of heart failure called tachycardia-induced cardiomyopathy, where all that irregularity in the rhythm and fast heart rates will cause the pump to weaken. So that's one of the dangers of AFib. The other danger of the AFib is, like Dr. Mulukutla says, is that when the heart chambers are quivering, blood stays there a lot longer than it should. So whenever blood is in one place for too long, it'll clot off. Right. And then those clots can then go out to the body and cause all sorts of problems. The main problem that we fear is a stroke. A clot makes it to the arteries of the brain, causes an occlusion, and now you have a cerebral infarct or a stroke. So, most patients that have AFib have other comorbidities. High blood pressure, coronary artery disease, diabetes, maybe they've had prior strokes already. So the more of those entities that you have in one patient, the higher the stroke risk is. So once a patient reaches a certain stroke risk, we would recommend blood thinners. That would really be one of the few ways to reduce the chance of a clot forming in this chamber right here, which is the left atrium. There's this anterior portion of the left atrium called the left atrial appendage. And the majority of the clots that cause strokes in AFib come from that particular area.
Interesting.
So, now we're using a medication, a blood thinner, that helps reduce the chance of forming clots, but at the same time increases your chances of having spontaneous bleeds. So you can have a spontaneous brain bleed, bleed in the stomach. So some patients, they have a high bleeding risk. So you have to kind of balance, is the stroke risk higher or is the bleeding risk higher? In those patients that have a higher bleeding risk and stroke risk, you would consider this device called a Watchman, which Dr. Mulukutla also does. And basically, it's a plug. It plugs up that area where the majority of the clots form with AFib. And it allows patients
Capture clot, so to speak. Or
to try to prevent the clots from happening.
Blood doesn't get in there and clot off. So it just plugs off that problematic area. So it allows these patients to safely come off anticoagulation. It substantially reduces their stroke risk. So that's what this is. This is called a Watchman device.
Okay. And how difficult is it to place that in?
So today we did a few of them, and one of them, to Dr. Espinoza's point, she had a brain bleed, we call intracranial hemorrhage, while being on blood thinners. So as a result of that, she also had a stroke. And so to get her off of the medicines, we did this procedure today. Then there's another gentleman who had a stomach bleed and had needed transfusions of blood cells to make his blood counts come up. And unfortunately, we also have patients, these are expensive medications that are hard to afford or obtain, and that can also be a reason. There's a lot of different reasons, and this will probably become more and more common as we do these things. But they can be challenging to put in, but generally it's a procedure that we do today, and then the patients can go home tomorrow. But it takes about an hour or two. We put the patients to sleep, and we end up basically putting this plug within the heart. Again, without opening the heart, which is an amazing thing to do.
Yeah, exactly. And this has been around for how many years would you say?
About 5 years.
About 5 years. So it's still relatively new.
Yeah, it's not very long.
Okay.
And his first patient, actually, I saw in clinic that we did here in the borderland just this last week. She's doing great. And I think now, as a community, we've probably done north of 500 or 600 of them.
Oh, my goodness.
So
okay.
it's not something that is for everyone,
Right.
but there is the benefits to these patients. In the old days, we would just tell people, hey, just come off your blood thinner and just hope and pray.
They've been done.
Now we have options. It's for certain patients, but you have to see about it. But it's just new technologies that we want to be able to have for our area and our community. I think it's great that we're able to do these different things now, so patients don't have to go elsewhere.
I thank you all so much for, yes, discussing this, but honestly for bringing visuals, which is super helpful to everyone. And Diego, who's the one that puts this program together and edits everything, I keep saying his name as he's pointing at things around here too. And there's some stuff that we didn't even get to. So come back. I kind of love that. Thank you so much. We've been speaking today with Dr. Mulukutla. How you say his name differently than I do?
Mulukutla.
Mulukutla. See, I've been saying it.
We had a sale on used and we bought them all.
We had a sale on you. Do you do open up mic night sometimes?
I think my wife would say my jokes are pretty stale.
Well, you describe things well, and I think that's very helpful to the audience. Dr. Espinoza, thank you so much for being here. Absolutely. Again, this has been Advancements in Cardiology, and if you miss part of this show, you can always catch this in 3 different places. There is on pbselpaso.org. You can just look up the El Paso Physician. Also on the El Paso County Medical Society website, and that is epcms.com, or youtube.com, and just put in the words the El Paso Physician, and then often you can find whatever ailment that you're looking for, whatever the topic is, and it will pop right up. But we will see you next time. Thanks again for joining us. I'm Catherine Berg, and this has been the El Paso Physician.
Hello, I'm Dr. Allison Days, a past president of the El Paso County Medical Society. The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician to your home for the last 27 years on PBS El Paso. We hope that you have enjoyed this program and others we have previously recorded. They are archived on our website, epcms.com, kcostv.org, or you can also locate them on YouTube by searching for The El Paso Physician. If you should have any questions relating to this program, please feel free to email us at epmedsoc@aol.com, and we will try to have our experts answer your questions. Thank you for watching, and please feel free to provide feedback at epmedsoc@aol.com.